Our goal today is to cut through that complexity and give you the blueprint of how blood gets into, and just as critically, out of your brain.
Oh.
We're synthesizing a really detailed anatomical and functional review of these pathways.
Right.
And we need to understand not just where the arteries go, but why they take those very specific, sometimes bizarre-looking paths.
And the fundamental reason for all this incredible complexity,
Yeah.
it really boils down to the brain's shocking metabolic demand. I mean, it's just off the charts.
And it really is.
If you were looking at, say, the wiring diagram for a skyscraper, the brain would immediately be flagged as the ultimate single point of failure based on its energy use. We learned from the source material that the brain is characterized by this densely branching arterial network. It gets a staggering 15% of the entire cardiac output.
15%. Just think about that. 15 out of every 100 heartbeats. That blood is ticketed straight for the brain.
And it uses 20% of the body's total oxygen. It's a monster.
That level of demand, 20% of the oxygen for an organ that's only about 2% of your total body weight, that explains everything. It explains why the architecture is designed for immediate, continuous, uninterrupted flow.
This is not a system that tolerates downtime.
Not for a second. If that blood supply is acutely interrupted for more than just a few minutes, and we're talking, maybe 3 to 5 minutes tops, it causes permanent neurological damage.
That's it, a few minutes.
And that's why when we look at the pathology later on, you'll see that disturbances like ischemic stroke, which is a blockage, and hemorrhage, a rupture, they are major, major contemporary sources of morbidity and mortality across the globe. Understanding the plumbing is absolutely essential to understanding the catastrophe when it fails.
So let's set the stage for the system's architecture. The source is laid out pretty clearly. The entire blood supply comes from two major interconnected systems that meet up at the base of the brain.
Right.
You've got the internal carotid arteries, which handle the entire front or anterior circulation. And then you have the vertebral arteries, which manage the posterior circulation in the back.
And that's the core dichotomy you need to hold in your mind, front and back. These major vessels, they diverge from their main trunks to supply every single critical region, the forebrain, midbrain, cerebellum, the brainstem.
All of it.
But here's a crucial point, and it's vital for clinical context. All of these major vessels, at their most critical proximal levels, they lie in what's called the subarachnoid space at the base of the brain.
And that location, that has huge consequences, doesn't it?
Massive. It means when one of those vessels ruptures, you get this high-pressure devastation of a subarachnoid hemorrhage because the blood is pouring directly into that fluid-filled space surrounding the brain.
Okay, so let's unpack that anterior circulation first. The internal carotid artery, or the ICA, as you said, it's not just one artery. It's more like a monumental winding journey with 4 distinct parts.
That's a great way to put it, a journey.
And this ICA system is the main blood supply to the major lobes of the cerebral hemisphere, though, as we'll see, it gets some pretty crucial collaboration from the posterior system.
It does. But the path of the ICA itself is a truly remarkable piece of hydraulic engineering. It really reflects the need to protect and stabilize this high-volume flow before it ever reaches the fragile brain tissue.
So let's follow that path segment by segment. Where do we start?
We start outside the skull. The first part's the cervical part. This is the simplest segment, really. It just descends straight up in the neck from the common carotid bifurcation, usually around the level of the C3 or C4 vertebra, all the way up to the base of the skull.
So a relatively straight shot, a fast ascent.
Exactly. But the path gets significantly more complicated the moment it enters the temporal bone. That's when it transitions into the petrose part.
Okay.
The ICA enters the skull through a dedicated tunnel called the carotid canal, which is right within the petrose portion of the temporal bone. From there, it ascends anteromedially, so forward and toward the middle, and then it takes a sharp horizontal turn.
And it's getting pretty close to some important stuff in there, I'd imagine.
Extremely close. This segment is separated from the trigeminal ganglion by just a thin layer of bone and dura. Sometimes that separation isn't even complete. And this segment is essential because it gives off 2 specific branches here, including one called the caroticotympanic artery, which actually links the main brain supply to the structures of the ear.
Wow. Okay, and then we move into the segment that's, well, it feels like it's straight out of a horror movie for surgeons. The cavernous part.
Ah, yes, the cavernous sinus. This is where the ICA ascends toward a bony landmark called the posterior clinoid process. It passes medial to the superior orbital fissure, and then it pierces the dura and the roof of the cavernous sinus itself.
And what's so terrifying about its environment here?
It's the intimacy. The cavernous part of the ICA is literally surrounded by the cavernous sinus. It's an artery sitting inside a lake of slow-moving venous blood, and it's in extremely close relation to a whole host of vital cranial nerves.
Which ones are we talking about?
We're talking about cranial nerve the third, the oculomotor, 4, the trochlear, V1 and V2, which are the ophthalmic and maxillary divisions of the trigeminal nerve, and 6, the abducens. They're all packed in there right next to this high-pressure artery.
That relationship sounds terrifyingly tight. Given how vulnerable the ICA is in that sinus, a high-pressure artery surrounded by low-pressure blood, is there any evolutionary reason for this? Why are those vital nerves forced to lie so close to a high-pressure line? Isn't that just a massive design flaw?
It certainly appears to be an unavoidable consequence of just cranial-based space constraints, but you're right. It absolutely creates a massive risk profile. The source material specifically notes that the trochlear nerve is situated in the lateral wall of the cavernous sinus, right next to this pulsating vessel.
And the clinical link must be immediate.
Immediate and profound. Any cavernous sinus disease, whether it's a tumor, inflammation, or a vascular lesion like a carotid cavernous fistula, which is an abnormal connection often from trauma, it can cause what we call ophthalmoplegia.
Palsies of the eye muscles.
Exactly. Palsies affecting eye movement because those nerves are directly compressed or injured. The source also notes a small meningeal branch that comes off here, which goes on to help supply the dura mater, just further illustrating how dense this network is.
Okay, so after that incredibly precarious passage, the ICA finally reaches its destination with the last part.
The intracranial part. This segment pierces the dura mater, turns back on itself just below the optic nerve, and then runs posteriorly and superiorly. It finally terminates by dividing into the two critical vessels of the anterior circulation, the anterior cerebral artery, the ACA, and the middle cerebral artery, the MCA.
And this whole winding path, it's not random, is it?
Not at all. This brings us back to the architecture. The combination of the petrous, cavernous, and intracranial parts is typically associated with what's known as the second bend, or the sigmoid course, of the internal carotid artery. This S-bend, this curvature, is not arbitrary.
It's a buffer.
It's theorized to act as a critical hydraulic buffer. It smooths out the flow surges and pressure changes that are just inherent in your systemic circulation, like when you stand up really quickly or cough or sneeze before that high-pressure blood smacks into the delicate vessels of the brain. It's absolutely essential for maintaining a consistent cerebral perfusion pressure.
So let's move on to the ICA's final delivery system, two big terminal branches. Let's start with the anterior cerebral artery, the ACA. It's the smaller of the two, but it's critical for the brain's medial or middle structures. Right. And we define the ACA in two main segments. The first part, the A1 segment, is the horizontal portion. It extends from the ICA bifurcation to the point where it meets the anterior communicating artery, or the ACOM.
And that A1 segment is a bit of a wild card, isn't it?
It's functionally critical because of its variability. In some people, the A1 segment can be hypoplastic, underdeveloped, or even completely absent on one side. Wow. Which means the brain supply for that entire territory must rely completely on the contralateral artery, the one from the other side, through that ACOM safety bypass bridge. This is one of the very first clues that the famous circle of Willis isn't always complete or reliable.
And after that communication point, we get the next segment. That's the A2 segment. It takes over right after the ACOM. It runs superiorly, up along the rostrum of the corpus callosum, and then follows its superior surface. This is where the ACA really starts to distribute its branches, both to the cortex and deep inside.
And what parts of the cortex does it supply?
Its cortical branches supply the medial surface of the orbital and frontal lobes, including structures like the gyrus rectus and the medial orbital gyrus. Functionally, the ACA territory supplies the brain's highest structures. We're talking about motor control for the lower limbs, for your legs, and the complex areas that govern motivation, emotional processing, and executive functions related to planning and personality.
But maybe even more critical are the deep branches, the ones that just plunge straight into the center of the brain.
Yes, these are absolutely vital. These long, penetrating branches supply the anterior limb of the internal capsule, the medial portions of the globus pallidus, and the anterior part of the putamen.
We're talking about the famous lenticulostrate perforators.
We are. And these aren't just small pipes. They're high-pressure feeder lines going straight into the engine room, the deep motor control structures. They are tiny, high-resistance vessels that come off almost at a right angle from the A1 segment, which makes them very vulnerable.
Okay, now let's turn to the other main branch, the real workhorse, the middle cerebral artery, or MCA. This is the larger terminal branch of the ICA.
And it is by far the most common site of major ischemic stroke.
It runs a dense, protected course through that big groove on the side of the brain, the lateral sulcus or the Sylvian fissure.
It does, and we break it into segments, too. The M1, or sphenoidal segment, runs deep in that lateral sulcus. It's relatively short, but it terminates pretty quickly by dividing into the major trunk arteries right there at the sulcus itself.
And after M1?
After M1, we get the M2, or insular segment. This part runs over the insula. That's a deep, kind of hidden part of the cortex, and it gives off branches that rapidly spread out like a fan to supply massive portions of the frontal, temporal, and parietal lobes.
The cortical branches of the MCA, the later segments, they supply the vast majority of the lateral surface of the hemisphere.
They do. This includes all the major functional areas we associate with speech, language, sensation, and voluntary movement, specifically the primary motor and sensory cortex areas for the face and your upper body.
So if the lights go out here?
If the lights go out here, you lose the ability to talk, to write, or to move an entire side of your body. It's devastating.
And just like the ACA, the MCA has its own set of absolutely critical deep perforators, also called the lenticulostriate arteries.
Yes, and this particular set of arteries is paramount. They are small, deep branches that enter the brain through an area called the anterior perforated substance. They're vital because they supply the posterior limb of the internal capsule, the globus pallidus, and the lateral portion of the putamen.
So a tiny lesion here means a huge functional problem.
A huge deficit. You've cut off communication to the body's main motor and sensory superhighway. This MCA set of lenticulostriates are, as we'll discuss in more detail, the most famous stroke targets because of their tiny size and the immense direct pressure they have to bear.
We've established the entire anterior circulation, all powered by the ICA. So now let's pivot 180 degrees and look at the posterior system, the vertebrovascular setup. And this one takes a remarkably different and maybe more secure route into the skull. We're talking about the vertebral arteries, or VAs.
That's right. The VAs originate as branches of the subclavian artery, way down in the lower neck. And they take this highly protected path, ascending up through the little bony holes, the foramina of the upper 6 cervical vertebrae.
So they're running inside the spine, essentially.
In a way, yes. These bony channels provide a huge amount of mechanical protection against trauma or sudden neck movements. It's a stark contrast to the ICA's passage through the more open carotid canal and that dangerous cavernous sinus.
That seems like a much more buffered, structurally stable path.
It is, and it has to be. This system supplies the brainstem, which controls all of our life-sustaining functions like breathing and heart rate. It needs that protection. So after traversing these bony tunnels, the VAs pierce the dura and enter the skull through the foramen magnum, the big hole at the base.
And then they join up.
They do. The two VAs eventually converge on the anterior surface of the medulla oblongata, right at the level of the lower border of the pons, and they form a single large vessel we call the basilar artery.
And they give off some important branches along the way.
Very important ones. Along their journey, they give off the posterior inferior cerebellar artery, or PICA, which is crucial for supplying the lower cerebellum and the lateral medulla. They also give off the anterior and posterior spinal arteries that, as the name suggests, descend to supply the spinal cord.
The basilar artery, then, is definitely a central highway. It's one big median vessel. Tell us about its path and its branches.
So the basilar artery runs straight upward in what's called the pontine cistern, lying right on the front surface of the pons. It terminates pretty dramatically at the upper border of the pons by splitting, or bifurcating, into the two posterior cerebral arteries, the PCAs.
So it's the single main conduit for the whole back half of the brain.
It is. And what's fascinating here, according to the synthesizing research, is that its size and velocity are highly reactive to changes in your systemic blood pressure. It's fundamentally engineered to respond instantly to the body's overall hemodynamic status to ensure that pressure remains stable in the brainstem.
And given that stability requirement, what are the key arteries that peel off the basilar artery as it goes up?
Okay, so starting from the bottom and moving up, first we have the anterior inferior cerebellar artery, or AICA. This artery runs inferiorly to supply the anterior and inferior parts of the cerebellum. And crucially, AICA gives off the internal auditory artery, also called the labyrinthine artery.
And that's
That supplies the hearing and balance structures of your inner ear. So a blockage here can cause sudden deafness and vertigo.
wow, that sounds like a very specific and devastating stroke syndrome.
It absolutely is. Moving up from there, we have numerous very small direct branches called the pontine arteries. They just saturate the pons, providing blood to all those essential tracts and nuclei that manage basic life support functions.
And at the very top.
And finally, just before the basilar artery terminates, it gives rise to the superior cerebellar artery, or SCA. This one supplies the superior surface of the cerebellum and critical parts of the midbrain, including areas that are responsible for eye movements and coordination.
So the basilar artery's final act is splitting into those two posterior cerebral arteries, the PCAs. This marks the furthest reach of the vertebrobasilar system, but it's also the bridge, right? It connects it back to the ICA system via the circle of Willis.
That's the connection point. And we define the PCA structure in two main segments as well. The P1 segment, or the precommunicating segment, extends from that basilar bifurcation up to the point where it joins the posterior communicating artery, the PCOM.
And this P1 segment is critical for the deep structures.
Functionally critical, yes. It gives off these tiny, deep, perforating branches, thalamic and midbrain branches that supply the core relay stations of the brain.
And then the P2 segment wraps around the core of the brain.
Correct. P2 is the post-communicating part. It runs around the cerebral peduncle, weaving its way back to reach an area called the quadrigeminal plate. From there, its cortical branches spread out to supply the medial and inferior surfaces of the temporal lobe.
So areas involved in memory, like the hippocampus.
Precisely. And it also supplies the medial and lateral aspects of the occipital lobe.
So the PCA is essentially painting the back and the bottom of the brain, a territory we often associate with memory and, of course, sight.
Exactly. And functionally, the most famous branch of the PCA is the calcarine branch. This is the artery that supplies the primary visual cortex, located deep in the occipital lobe.
So an interruption of the PCA or the calcarine branch can immediately lead to blindness.
It can, often a very specific form of partial or complete blindness in the corresponding visual field. And let's not forget, the deep branches from the PCA supply crucial central areas like parts of the thalamus and the medial geniculate body, which means even a tiny P1 segment stroke can be functionally devastating.
Okay, so if the ICA and the VV systems are the high-pressure incoming highways, then the circulus arteriosus cerebri, which we all know as the circle of Willis, is meant to be the brain's critical safety feature. It's the great circle of communication.
It's an anatomical arterial anastomosis, a connection found right at the base of the brain. And its whole purpose is to link the ICA, the anterior system, and the vertebrobasilar, the posterior system, together. It's designed, in theory, to be able to redistribute flow in case one of the four main feeder lines fails.
Let's just quickly confirm the components that physically make up this ring.
Okay, so the components are the single anterior communicating artery, the ACOM, the two anterior cerebral arteries, specifically their A1 segments, the proximal segments of the two internal carotid arteries, the two posterior communicating arteries, the PCOMs, and the two posterior cerebral arteries, their P1 segments.
So it's a closed loop, ensuring 4-point redundancy. It sounds perfect in theory, like a guaranteed safety net. What is its practical functional role? And I guess, where does the paradox of its failure come in?
Well, its primary functional importance is, as you said, allowing blood to be shunted between the four major input arteries when one is narrowed or stenosed. But here's where it gets really interesting. Based on synthesizing clinical data, our sources indicate that although it's functionally important, the collateral capacity of the circle of Willis varies dramatically among individuals.
So it's not standard equipment.
Not at all. It is often incomplete. Research shows that it's sometimes structurally incomplete. A piece is just missing. Or in many people, key bridging segments like the posterior communicating artery are simply too small, what we call hypoplastic, to redistribute flow effectively when they're actually needed.
So the presence of the structure doesn't guarantee the presence of the function. It's a lottery.
It is precisely a lottery. The circle's efficacy is the single biggest determinant of the degree of neurological deficit in cases of major vessel occlusion. A functionally incomplete circle often causes a severe ischemic stroke because the brain simply cannot compensate.
Can you give an example?
Sure. Let's say the ICA is blocked on the left side, but if the left PCOM, the bridge from the back, is hypoplastic and tiny, the posterior circulation can't adequately feed the anterior part of the brain. The result is a large, severe stroke. The collateral pathways exist on the diagram, but the volume of flow they can deliver is too small, or the time it takes to shunt that blood is just too long.
Now that we've mapped the major vessels and their sometimes faulty protection system, let's see how they divide up the labor across the central nervous system. Let's start with those deep, critical structures like the brainstem.
The brainstem, especially the medulla oblongata, is an incredibly dense critical structure, and its blood supply reflects that importance. It's supplied by a complex patchwork of smaller vessels. You've got branches from the vertebral arteries, the anterior and posterior spinal arteries, the PICA, and the basilar artery all contributing.
That redundancy seems vital there.
Absolutely vital. Because the brainstem controls essential functions like respiration, consciousness, and heart rate, a stroke here is usually just devastating.
And moving just behind that to the cerebellum.
The cerebellum is supplied by the three major cerebellar arteries we mentioned: the superior, the anterior inferior, and the posterior inferior cerebellar arteries, SCA, AICA, and PICA. All three are major branches of the vertebrovascular system, which really highlights the posterior circulation's ownership of coordination and balance.
What about sensory relay points, like the optic chiasma and tract, where all the visual information crosses over?
That's a great question. That area relies on a collaborative supply. It gets blood from the ICA, from the anterior communicating artery, and from branches of both the anterior and posterior cerebral arteries. The visual system is so critical that its supply is drawn from the confluence of both the anterior and posterior systems.
And the core relay centers, the diencephalon. We're talking about the thalamus and hypothalamus, the relay centers and endocrine regulators.
The diencephalon is supplied mainly by small, deep, perforating branches. These typically arise from the PCA's P1 segment, the basilar artery, and the posterior communicating artery. The ICA and ACA also contribute a little bit, making it clear that the diencephalon sits right at the intersection of all the major systems. These deep vessels are tiny and extremely susceptible to damage from high blood pressure, but they feed the entire internal regulatory core of the brain.
Okay, this next segment deals with what is maybe the most vulnerable territory for stroke, those deep motor pathways where the high-pressure perforators are most active. Let's start with the basal ganglia.
Right. The basal ganglia, which include the globus pallidus and the putamen, are supplied by perforating arteries that arise from the ACA, the MCA, and another one called the anterior choroidal artery. These create dense capillary networks that are essential for smoothing out and initiating voluntary motor control.
And this is where the pathology connection gets very specific and really illustrates the functional importance of blood flow. The source mentioned that ligation of this vessel group, so interrupting the flow, can actually mimic Parkinson's disease.
That is a powerful and classic illustration. The globus pallidus is central to the motor circuit that connects the cortex, the basal ganglia, and the thalamus. Interrupting its blood supply disrupts this complex motor loop, and the result is movement disorders that bear a striking resemblance to the rigidity and tremors we associate with Parkinson's.
So it highlights just how acutely dependent these specific deep nuclei are on continuous, highly regulated blood flow.
Precisely. And moving right next to that, we have the internal capsule. This is the superhighway for virtually all motor and sensory information traveling to and from the cerebral cortex.
And its blood supply.
The internal capsule is supplied by central and perforating arteries, including the lateral and medial striate arteries, as well as the anterior choroidal artery. The internal capsule is this dense, packed bundle of descending motor fibers, the pyramidal tract, and ascending sensory fibers.
Which means a tiny infarct has huge consequences.
An incredibly small infarct, maybe only a few millimeters wide, can wipe out a huge amount of function on the opposite side of the body. It results in what we call pure motor or pure sensory strokes.
And it's those lateral striate arteries, the lenticulostriate branches off the MCA, that are specifically flagged in the source material as the most common sites for both hemorrhage and ischemic stroke because of their small caliber. Why is this specific group so notoriously weak?
It's really a matter of fluid dynamics. They are tiny vessels that arise almost at a right angle, perpendicularly, from the high-pressure MCA trunk. They have no opportunity to buffer or manage that pressure before they plunge deep into the brain substance.
So they're getting hit with the full force.
The full fire hose blast. Under chronic conditions like hypertension, these vessels are subjected to immense stress, which makes them highly susceptible to microscopic rupture, leading to a hemorrhage or thickening and occlusion, which leads to those ischemic lacunar strokes. They are tiny vessels bearing immense pressure, and their occlusion leads to devastating classic deep strokes.
We've established the deep supply. Now let's quickly map out the cortical surface, which is what dictates the macro-level symptoms of a major stroke, according to the source material.
Right, and this anatomical mapping is really the foundation of clinical neurology. The ACA supply covers the medial surface of the hemisphere. It extends from the frontal pole all the way back, though it usually spares the very tip of the occipital pole.
And functionally.
Functionally, since the motor cortex is mapped upside down on the brain, this territory governs lower limb function, so your leg and your foot, as well as those complex, nuanced behavioral and emotional controls that are associated with the medial frontal lobe.
And then the MCA supply. This is the biggest chunk, right? It pretty much monopolizes the entire lateral surface of the hemisphere.
Exactly. This enormous territory includes the entire sensoromotor strip, meaning the primary motor and sensory areas for the face and the upper body, as well as the speech and language centers, Broca's and Wernicke's areas, and the auditory cortex.
Which is why MCA strokes are the most common and present so dramatically.
It is. They often present with a dramatic paralysis or hemiparesis and aphasia, which is difficulty with speech.
And finally, the PCA supply.
The PCA covers the inferior surface of the hemisphere and, most importantly, the entire occipital pole and the visual cortex within it. A stroke in this territory results in very distinct visual field cuts. It often spares the very central vision, we call that macular sparing, because of a dual blood supply, but otherwise it can cause blindness in large parts of the visual field. It's a precise anatomical mapping that dictates the exact nature of the neurological deficit you see in a patient.
Okay, so now we transition from the perfect anatomy to the all too common failures of the system. Let's begin with ischemic stroke, which accounts for the vast majority of all cerebrovascular events.
Right. Ischemic stroke is fundamentally defined as the clinical syndrome of a rapidly developing focal neurological deficit that's due to local ischemia. In other words, a reduction of blood supply to a portion of the brain. And that lack of blood flow can stem from two primary mechanisms.
So either we have a blockage or we have a pump failure.
That's a perfect way to put it. The first and most common is local vascular obstruction. That could be an embolus, a clot that travels from somewhere else like the heart or neck and gets lodged in a brain artery, or a thrombosis, which is a clot that forms right there on the spot, usually due to severe atherosclerosis or hardening of the arteries.
On the second mechanism.
The second is diffuse low flow. This is typically related to systemic hypotension or cardiac arrest, where the brain tissue is underperfused globally because the pump itself isn't working right.
And our sources emphasize that when those deep vessels are involved, it leads to very distinct types of strokes.
Absolutely. Strokes that involve the lenticulostriate or other perforating arteries cause small, deep infarcts, which are known clinically as lacunar strokes.
Cavrosia, like a lake.
Exactly. They're named after their appearance on imaging. They look like small lakes of tissue destruction, and they often occur very specifically in the basal ganglia or the internal capsule. And because the internal capsule is such a dense bundle of fibers, even these tiny lacunar strokes can cause severe pure motor or pure sensory deficits.
Now, moving from blockages to a failure of structural integrity, let's talk about aneurysms and hemorrhage.
Cerebral aneurysms are these balloon-like swellings that occur most commonly on the cerebral vessel wall. They're found very frequently at the sites of vessel bifurcations, the points where an artery splits.
And usually around the circle of Willis.
Specifically around the circle of Willis or its major branches. Bifurcations are points of turbulent blood flow where the sheer force of the blood constantly stresses the vessel wall. Over time, that can lead to weakness and the eventual formation of what we call a saccular or berry aneurysm.
And while a lot of small aneurysms might be silent, large ones can cause problems just by their size, right? By compressing things around them.
Correct. The mass effect is significant. We learned a classic example, a posterior communicating artery aneurysm. The PCOM runs directly adjacent to the third cranial nerve, the oculomotor nerve.
The one that controls the eye.
Right. So if an aneurysm on the PCOM grows, it compresses that nerve, causing a very specific set of deficits. Dilation of the pupil, a defect in the nasal visual field, and ptosis, which is a drooping of the eyelid. This specific triad is often the very first warning sign of an expanding PCOM aneurysm that's about to rupture.
But the truly devastating event is when that balloon actually does rupture, leading to a subarachnoid hemorrhage, or SAH.
Yes. And SAH is bleeding directly into the subarachnoid space, that fluid-filled area surrounding the brain where all those major vessels of the circle of Willis are running. And it is overwhelmingly caused by the rupture of an intracranial secular aneurysm.
The clinical presentation is unmistakable,
Yeah.
and it's often described in these really dramatic, visceral terms.
It is. Patients frequently describe it as the worst headache of my life, or feeling like they were suddenly hit with a hammer. The sudden influx of high-pressure arterial blood is incredibly irritating to all the surrounding nerves and structures.
So the blood itself is the problem.
Yes, the blood bathes the deep surface of the cerebral cortex and the cisterns at the base of the brain, leading to those severe headaches, vomiting, a stiff neck, and a massive risk of secondary complications like hydrocephalus, or, critically, something called vasospasm.
Okay, wait, let's expand on that secondary complication, vasospasm. Why does a hemorrhage itself cause a secondary ischemic event? That seems counterintuitive.
It's a major, major challenge in managing SAH. The presence of blood breakdown products in the subarachnoid space is profoundly toxic and irritating to the vessel walls. So, within days of the initial rupture, the major arteries that are running through that bloody space, like the ACA and MCA, can start to dramatically constrict or spasm.
So they clamp down.
They clamp down hard. This narrowing reduces the blood flow distal to the spasm, which essentially causes a second delayed ischemic stroke. And that can be even more damaging than the initial hemorrhage itself. Dealing with this delayed ischemia is a primary focus of neurocritical care after an SAH event.
We've established that the brain has this amazing system of backup plans, the communicating arteries, but we've also heard that they often fail. So let's delve into this paradox of collaterals and their functional limits.
Right. The primary role of the communicating arteries, the PCOM and the ACOM, is to provide these anastomotic pathways or collateral flow when a primary supply line, say a major ICA or MCA trunk, is impaired. But the fundamental challenge here is one of volume and time.
And what evidence do we have that the system is at least trying to compensate, even when it ultimately fails?
Well, we see physiological confirmation. The sources note that when a severe occlusion occurs, the distal arteries, the ones further down the line from the blockage, are sometimes found to be dilated. This suggests an immediate physiological effort toward collateral compensation, trying to use small existing channels to redirect flow.
But it's not enough.
It's often insufficient. Because the collateral volume is fundamentally small, these little channels simply cannot deliver the vast amount of oxygenated blood needed by the huge tissue volume that is now dependent on them.
So the effort is there, but the capacity just isn't equal to the demand.
Exactly. And even in cases where there is technically adequate collateral flow established, the time required for that flow to reach the now ischemic tissue through the slower alternative route is often unrecoverably long. The brain tissue that relies on the blocked artery, we call that the ischemic core, is dying within minutes. The tissue around it, the penumbra, is starving. And if that collateral supply can't reach the penumbra quickly enough, that tissue will die too. The brain just runs on an incredibly fast clock, which explains why severe damage persists despite the presence of an anatomical backup system.
Speaking of time limits and failure, let's discuss the watershed areas, or water zones. These sound like the brain's weak spots when it's under systemic stress, like pump failure.
That's a perfect way to put it. Watershed areas are regions of the brain that exist at the extreme edges of the major cerebral arterial territories. They're the areas where the ACA, MCA, and PCA distributions just barely overlap.
And why are these zones so uniquely vulnerable compared to the core supply territories?
Think of it like trying to water a vast garden with a sprinkler system when your water pressure is low. The plants closest to the main, high-pressure pipes, the core territories, they'll be fine. But the flowers at the extreme corners of the garden, those are the watershed areas, they will be the first to wilt when the system pressure drops.
Because the water just can't get there.
Exactly. They are critically dependent on sufficient perfusion pressure to push blood all the way to those distant capillaries. So if a patient experiences systemic hypotension, say a massive drop in blood pressure from blood loss or cardiac arrest, the vessels in these border zones are the first to be deprived of sufficient blood flow because the pressure drop hits them the hardest.
So the lack of blood flow isn't a local blockage in this case. It's a global pressure problem that's exposed anatomically by the limits of the arterial reach.
Precisely. And the evidence for this concept is powerful. Studies of brain pathology consistently show that the white matter in these border zones, for instance, between the ACA and MCA territories or the MCA and PCA territories, often shows signs of damage first. We even see evidence of a second arterial border zone where the terminal cortical branches overlap with the deep perforating branches. This complex overlap just underscores their unique vulnerability to global perfusion failure because they rely on the lowest pressure points of two different systems.
Okay, we've spent a significant amount of time on the high-pressure side of the system, the arteries. Now let's transition to the low-pressure side, the venous drainage system. This is the brain's critical system for removing metabolic waste and returning all that spent blood and cerebral spinal fluid back to the heart.
And it's a completely different system architecturally, and this is crucial to grasp. Drainage occurs through this complex system of deep and superficial cerebral veins. These veins then have to pierce the dura mater, that tough protective layer, and they empty into specialized channels called the dural venous sinuses, or DVS.
And these veins are different from the ones in the rest of our body.
Very different. Unlike systemic veins, cerebral veins lack muscular tissue, and critically, they lack valves.
Wait, no valves. So the drainage flow is basically just hope and gravity. It's relying entirely on pressure gradients. That sounds terrifyingly low-tech for the brain's sewage system.
It sounds simple, but it's highly functional, as long as that pressure gradient is maintained. The lack of valves means that flow is dictated by your posture, by your respiration, and by the general intracranial pressure. Any rise in pressure inside the head can immediately impede this venous return, which makes the whole system extremely sensitive to obstructions.
Okay, so starting with the surface drainage, the superficial cerebral veins. These handle the drainage of the surfaces of the cerebral hemisphere, and they empty directly into those nearby dural sinuses.
Right. Examples would be the superior cerebral veins, which cross the subarachnoid space to drain into the superior sagittal sinus. The middle cerebral vein, which drains the lateral sulcus area, typically drains into the cavernous sinus. And the inferior cerebral veins handle drainage for areas like the lateral temporal lobe, flowing into the transverse or petrosal sinuses.
And then there's the complex network for the veins of the posterior fossa, draining the brainstem and cerebellum.
This involves a complex venous plexus of vessels like the petrosal and transverse cerebellar veins. These drain the deep brainstem, the cerebellum, and the medulla, eventually flowing into the petrosal sinuses and from there onward to the internal jugular vein. This posterior network is essential for draining the structures that control all our vital functions.
But the internal core of the brain, the structures we discussed like the internal capsule and basal ganglia, that needs a dedicated deep drainage route. And that's the job of the deep cerebral veins.
Yes. The deep veins drain all the internal parts of the hemispheres, the basal ganglia and the internal capsule. And the key structures here are the internal cerebral veins. They form at the interventricular foramen, also known as the foramen of Monro, deep inside the ventricles, and they run posteriorly.
And they join up?
They eventually unite with the veins from the opposite side to form this single, massive collector, the great cerebral vein, which is historically known as the vein of Galen.
So the great cerebral vein is the main collector for all the deep structures, funneling everything from the center of the brain.
It is the ultimate bottleneck. It receives veins from the corpus callosum and another one called the basal vein of Rosenthal, which collects drainage from structures like the hippocampus and the temporal lobe. The great cerebral vein then empties directly into the straight sinus. This entire deep system is critically vital, as an internal venous obstruction here can rapidly lead to disastrous swelling, herniation, and death.
The dural venous sinuses, then, are the final, large collecting channels. And they aren't traditional veins with soft walls. They're channels located between the two tough layers of the dura mater. So they're like rigid drainage tubes that receive all the venous blood and eventually lead it out of the skull.
That's a great description. And we can trace the flow path through the system. It really begins with the superior sagittal sinus, which runs along the top midline of the brain, receiving all those superficial superior cerebral veins. Just beneath it, running along the inferior margin of the falx cerebri, is the inferior sagittal sinus.
And where do these main collecting channels meet up?
The inferior sagittal sinus joins with the great cerebral vein of Galen to form the straight sinus. The straight sinus runs posteriorly and then empties into the confluence of sinuses. You can think of this as the central venous traffic circle, and it's often located near the internal occipital protuberance on the inside of your skull.
The confluence sounds like the grand junction point.
It is. It receives the superior sagittal, the straight, and sometimes the occipital sinuses. From the confluence, the drainage splits and runs laterally into the paired transverse sinuses.
Okay.
These sinuses continue laterally until they curve down dramatically, forming the distinctive S shape of the sigmoid sinuses. The sigmoid sinuses are the continuation of the transverse sinuses, and they are what exit the cranial cavity through the jugular foramen to finally drain into the internal jugular vein, the main drainage outflow from the head.
And we have to circle back to the cavernous sinuses because they're involved in both high-pressure supply with the ICA and this low-pressure drainage.
Yes, these are critical bilateral sinuses. They are intimately related to the path of the ICA, and they also receive the superior ophthalmic veins from the face and the orbit. They drain posteriorly via the superior and inferior petrosal sinuses, which run over the petrous bone to join the sigmoid sinus or the internal jugular vein.
And that connection to the face is a problem, isn't it?
It's a huge potential problem. That anatomical link means that infections of the face can sometimes track inward to the cavernous sinus, leading to the highly dangerous condition of cavernous sinus thrombosis.
So if the arterial side is prone to high-pressure rupture and low-flow ischemia, what happens on the low-pressure drainage side? Let's look at intracranial venous thrombosis, or IVT, also known as cerebral venous sinus thrombosis, or CVST.
IVT is a less common but extremely serious pathology where blood clots develop in the dural sinuses or the intracranial veins. The causes are really varied. They can be related to trauma, localized infections, congenital coagulation issues, or even certain medications like hormonal contraceptives.
What makes this so devastating? Why is a clot in a low-pressure vein worse in some ways than a clot in a high-pressure artery?
It's the mechanism. An arterial clot causes local tissue death ischemia by cutting off the supply. A venous clot, however, obstructs the drainage. The obstruction causes the blood pressure in the veins and capillaries upstream of the clot to rise dramatically.
So it's a plumbing backup problem.
Think of it exactly like capping the sewer line. This high venous pressure has immediate disastrous consequences. It leads to reduced arterial inflow because the pressure gradient is gone. It causes massive brain swelling or cerebral edema, and eventually it leads to the rupture of the small pressurized capillaries. This results in what we call hemorrhagic infarcts, often termed venous infarction, and can lead to major deep hemorrhage into the brain tissue itself.
So back pressure is the killer, resulting in blood backing up until the vessels burst. What are the clinical signs that might distinguish IVT from an arterial stroke?
Because the pressure rises across the whole system, IVT often causes more generalized symptoms like a severe, persistent headache, nausea, or visual disturbance, rather than the very focal, localized deficits you see in an arterial stroke. In chronic cases, because the drainage failure leads to poor CSF absorption, the persistently high pressure can actually mimic hydrocephalus, or water on the brain.
And distinguishing this is critical.
Absolutely paramount, because the treatment blood thinners is often the exact opposite of what you'd prescribe for a hemorrhage caused by something like a ruptured aneurysm.
Okay, next, let's discuss arteriovenous malformations, or AVMs, which are a case of connecting the two systems incorrectly, mixing high and low pressure.
AVMs are developmental abnormalities of the blood vessels. They're estimated to occur in about 1 in 10,000 people. And structurally, an AVM is an abnormal tangle, which we call a nidus, of blood vessels that shunts blood directly from a high-pressure cerebral artery into a low-pressure vein, completely bypassing the necessary resistance and flow stabilization that's provided by the capillary bed.
That sounds like a catastrophic failure of the pressure regulation system, like a pressure bomb.
It is essentially a pressure bomb nestled inside the brain. They pose a very significant lifelong hemorrhage risk. The high-pressure arterial blood suddenly slams into the thin-walled, low-pressure venous system. The veins are simply not engineered to withstand that kind of systemic arterial pressure.
And they eventually fail.
They do. It leads to vessel enlargement, structural weakness, and eventual rupture. This rupture typically causes a catastrophic subarachnoid or intraparenchymal hemorrhage. AVMs are frequently diagnosed only when they first rupture, making them a true silent killer.
We've briefly touched on the close relationship between the venous system and the fluid dynamics of the brain. Let's just briefly reinforce that connection between the veins and the structures that produce our cerebrospinal fluid, or CSF, the choroid plexus.
Right. The choroid plexus, located deep inside the ventricles, produces CSF. That fluid circulates around the brain and spinal cord before it's reabsorbed, primarily through structures that are linked to the venous sinuses. The choroid plexus itself has a dedicated drainage system. The choroid plexus veins run back through the internal structures to drain eventually into the great cerebral vein of Galen.
And the choroidal vein.
The choroidal vein, running from the temporal horn of the ventricle, also receives veins from the basal ganglia before it joins that deep cerebral system.
So if that great cerebral vein, the Galen system, gets thrombosed, you're not only interrupting deep brain drainage, you're instantly choking the outflow for the CSF absorption system as well.
Absolutely. The close anatomical relationship between the deep vascular drainage and the CSF dynamics is crucial. Any condition like IVT that causes back pressure and stasis in the deep venous system will directly impede the absorption of CSF and increase the overall intracranial pressure. This is precisely why those chronic cases of venous thrombosis can present clinically just like hydrocephalus, because the brain is unable to drain its fluids effectively. The whole system is deeply interconnected, where a failure in one area can cascade into pressure problems across the entire cranial vault.
We've covered a massive amount of incredibly dense material today, from the S-bend engineering of the ICA to the complex valveless drainage of the dural sinuses. Let's just quickly summarize the key takeaways for you, the learner.
First, I'd say, remember the indispensable nature of the brain's supply. That 15% cardiac output and 20% oxygen consumption. That dictates everything about its vulnerability and the absolute necessity of its redundant architecture.
Second, understand the paradox of the circle of Willis. It is the anatomical protection, but its efficacy is highly variable among individuals. That anatomical incompleteness often means the difference between a minor stroke and a catastrophic one when a major feeder artery is compromised.
Third, and this is a big one, never forget the vulnerability of those deep perforating arteries, the lenticulostriate branches. They are small, high-pressure, perpendicular targets right off the MCA and ACA, and their involvement leads to those very common, functionally significant lacunar infarcts.
And finally, the crucial distinction between arterial and venous pathology. Arterial disease often causes ischemia from lack of supply or hemorrhage from a high-pressure rupture like an SAH. Venous disease, like IVT, is characterized by that deadly back pressure leading to edema and venous infarction, a completely different and very dangerous mechanism of tissue damage.
Understanding the plumbing really does dictate the proper diagnosis and treatment. It's a stunningly complex system, and its failure mechanisms are just as diverse.
So what does this all mean? We discussed how the combination of the petrous, cavernous, and intracranial parts of the internal carotid artery is typically associated with that second, protective S-bend or sigmoid course of the vessel. You know everything about the anatomy now, but stop and truly consider the dynamic forces involved. How does the body utilize that specific S-bend, that hydraulic cushion, to compensate for the immense pressure changes in flow dynamics every single time you stand up suddenly or run or even just laugh hard? The engineering complexity required to maintain consistent cerebral perfusion pressure through that curve, absorbing shock and stabilizing flow. It's just staggering.
And, building on that dynamic question, we focus heavily on the structures of the circle of Willis and the communicating arteries, and we noted how functionally varied they are. I'd encourage you to consider the implications of this hemodynamic communication between the ICA and the vertebral system. Our source material, naturally, is based overwhelmingly on clinical studies of adults who have acute pathology, stroke, aneurysms, trauma. But what hidden risks does the natural, unstudied variation in this collateral communication pose in the rest of the population, in infants, in children, in healthy adults? The brain is adaptable, but as we've detailed today, its fundamental anatomical weaknesses are often pre-programmed. They're only exposed when the system is challenged by pressure failure or occlusion. That adaptability is in a constant fight against some very hard anatomical limits.